I'm Dr. Sridhar K, consultant neonatologist. All of you are familiar with Apgar score, and actually it's a very interesting topic that the American Academy has a policy statement on Apgar score released in 2017. I'd like to go over some of the important details covered in that. As we all know, the Apgar score is an indication of the condition of the baby as well as the response of the baby to resuscitation. So we have the acronym APGAR, A for activity, P for pulse, G for grimace, A for appearance or skin color, and R for respiration. And depending on what condition the baby is in, we score it from 0, 1 or 2, and the maximum score is 10 and the minimum score is 0. So this was published, the committee statement, and in 2015. We all heard about Dr. Virginia Apgar, and she was a pioneer. She's actually an obstetric anesthetist who wanted to have a scoring system that was a rapid method of assessing the clinical status of the newborn at 1 minute of age, and also to assess the need for prompt intervention to establish breathing. So there are awards established after her. She's a very popular person, and as we all know, the Apgar score has been one of the mainstays in newborn assessment for a very long time. So we discussed the 5 components: color, heart rate, reflex or grimace, muscle tone or activity, and respiration. The color is often replaced by saturation in the current situation if you have the option. The components are given a score of 0, 1 or 2, and it quantitates the clinical signs of neonatal depression. So when there is perinatal depression resulting in hypoxia and ischemia, we have changes happening in the body. We have cyanosis or pallor may happen. The pallor indicates secondary apnea, as you can review on my NRP series video. Bradycardia also can happen in primary or secondary, but in more prolonged secondary apnea, the bradycardia is deep and it takes longer to respond. When the hypoxia is long enough and the ischemia has set in, the baby has reduced central nervous system function, so there is a depressed reflex response and hypotonia, and the respiratory center gets depressed, so there is apnea or gasping respiration. So if you go through my video on primary and secondary apnea, it would help you to understand this concept better. The score is reported at 1 minute and 5 minutes after birth for all infants, and then we continue to score it at 5-minute intervals if the score continues to be less than 7 till 20 minutes or so. If the baby needs resuscitation, we have to consider using the expanded Apgar score, which we will discuss later. The NRP statement indicates that the Apgar score is useful for conveying information about the newborn infant's overall status as well as the response to resuscitation. However, the resuscitation must be initiated before the 1 minute score is assigned. So obviously, if the baby is well, the delayed cord clamping will take a minute or so. So the obstetrician may be able to score the 1 minute score and hand over the baby to whoever is receiving the baby. However, the current NRP still states that if the baby is needing resuscitation, you would transfer the baby soon after birth. So such babies would be on the resuscitator, and we would score the 1 minute score after your initial assessment and steps have taken place. I would again refer you to the NRP series video that I've made on the algorithm. The Apgar score is not used to determine the need for initial resuscitation. It doesn't determine what steps are needed or when to use them. So it's not a guide to resuscitation. It's only an assessment of the condition of the baby, as I said, and whether there is a need for resuscitation, how the baby is responding. An Apgar score that remains 0 beyond 10 minutes of age may be useful in determining whether continued resuscitative efforts are needed, as very few babies with an Apgar score of 0 or 10 minutes have been reported to survive. The current NRP update has extended this to 20 minutes, and after 20 minutes, if there is no sustainable circulation, there is a consideration for discontinuation of resuscitative efforts. Asphyxia is defined as a marked impairment of gas exchange, which, if it's prolonged, leads to progressive hypoxemia, hypercapnia, and significant metabolic acidosis, which is a surrogative marker for both the hypoxemia and ischemia, which is an association. So that's why the asphyxia leads to hypoxic ischemic encephalopathy from brain damage from the reduced blood flow and the oxygenation. A persistently low Apgar score alone is not a specific indicator for intrapartum compromise because the baby may have a low Apgar score because the respiratory adaptation was not supported adequately after birth. It may not be a neurological factor, it may be something else which is hampering. And although the score is widely used in outcome studies, its inappropriate use has led to an erroneous definition of asphyxia. So you shouldn't use the Apgar score alone as a definition of asphyxia. The Apgar score is an expression of the infant's physiologic condition at a point in time, either at 1 minute, 5 minutes, or whenever you're scoring it. And this includes the subjective components. For example, the color and the tone, etc., can be subjective. There are many other factors which can influence the Apgar score, including maternal sedation or anesthesia, congenital malformations in the baby which affect the adaptation after birth. Prematurity affects the tone and the other aspects of the Apgar, including the respiratory distress that these babies may have. And if there is trauma, it may affect an inter-observer variability from the subjective components. In addition, the biochemical disturbance must be significant before the score is affected. So even if the baby is asphyxiated, not all asphyxiated babies have a low Apgar score. If the insult is prolonged, then the secondary apnea stage comes in when the score gets more affected. The tone, color, and reflex irritability may be subjective, as we discussed, and it partially depends on the physiologic maturity of the infant. The healthy preterm infant with no evidence of asphyxia may actually receive a low score because the tone may be affected, the activity may be affected just because of the prematurity. The incidence of the low Apgar score is inversely related to birth weight as well, and a low score cannot predict morbidity or mortality for any individual infant. So this is very important to remember that even if the Apgar score is low, we cannot strongly predict for that baby, even though in a population group, you may be using it to predict. It's inappropriate to use Apgar score alone to diagnose asphyxia, as we mentioned earlier. In terms of Apgar score and resuscitation, the 5-minute Apgar score, and particularly a change in the score between 1 and 5 minutes, is a useful index of how the baby is responding to resuscitation. So this again depends on the condition of the baby, how far into the secondary apnea the baby was when you started resuscitating, as well as the effectiveness of the resuscitation measure. So with the NRP guidelines, there is strong focus on you're getting adequate chest rise before you move on to the next stage. So hopefully the resuscitation will be done appropriately. The baby will respond, but you may need to think of other things like the H and T's if the baby is not responding. If the Apgar score is less than 7 at 5 minutes, the NRP guidelines state that the assessment should be repeated. So this is an ongoing assessment to see the response of the baby. What is the expanded Apgar score? So when we are actively resuscitating the baby, the Apgar score assigned is not equivalent to a score assigned to a spontaneously breathing infant. Actually, you're supporting the baby, and what you're scoring is actually a response to the support you're giving. So it's not the spontaneous Apgar score. There is no accepted standard for reporting an Apgar score in infants undergoing resuscitation after birth because many elements contributing to the score, like the respiratory effort, the color of the baby, and the tone, even once oxygenation improves and the perfusion improves, the tone starts improving. They're altered by the resuscitation process. Hence, the ACOG suggests the use of an expanded Apgar score. So what do we mean by an expanded Apgar score? It's the same format, the same scoring, but you add more details like what criteria gives you the score at each certain stage when you're scoring, and also what resuscitative measure the baby is needing at each stage. So if you look at the expanded Apgar score, you clearly know that the baby was intubated, for example, and the baby's respiration was through the AT tube. If the baby heart rate was there but with the chest compression, then it's a different story. You're obviously going to write the spontaneous heart rate when you're counting in between the assessments. The medication use would also guide you. So the score should be recorded in the appropriate place at specific time intervals, and the additional resuscitative measures are recorded at the same time that the score is reported by using a check mark in the appropriate box. So you tick here if the baby has endotracheal tube, you tick here if the baby is getting PPV, and so on according to the time of assessment. So this is going to be a very valuable record, and especially with medico-legal implications, I think everyone should start considering moving towards expanded Apgar score. It also removes the subjectivity to an extent and has a systematic, objective way of recording the Apgar score. Of course, some elements still remain subjective, but you're thinking about it more carefully. Again, one consideration here is that the obstetrician should not be thinking too much about the Apgar score. They should be thinking about the actual condition of the baby. So if the baby is progressing, the score, usually we may need to think the score, and if you're not able to multitask, you may not be able to shout out the score at 1 minute or 5 minutes, and it doesn't look good to change the score later because it's a medical legal implication as well. So it's better that we announce to the obstetrician the actual condition of the baby and what intervention is needed, and then you complete this form and give the score at the end of the active resuscitation process. In terms of prediction of outcome, the 1 minute Apgar score of 0 to 3 does not predict an individual infant's outcome. The 5-minute Apgar score of 0 to 3 correlates with the neonatal mortality in large populations, but for individual baby, it may not help you to predict the future neurologic dysfunction. So the severity of the encephalopathy, the improvement of the baby's condition, the cord gas, these may all have individual values when you combine them, and the MRI picture as well, if you need to do one. So we can safely say that the 1 minute Apgar score doesn't have much meaning at all, and the more prolonged the score is, the higher the risk to the baby. So suppose you have a score of 3 or less at 10 minutes, 15 minutes or 20 minutes, your predictivity in the population score will increase. A low 5-minute Apgar score clearly confers an increased relative risk of cerebral palsy, and it may be as high as 20 to 100-fold over that of babies with a 5-minute Apgar score of 7 to 10. So if you have a low Apgar score of 0 to 3, you have a 20 to 100-fold increased risk of cerebral palsy. But for an individual baby, you cannot clearly say what the risk is. It depends on the course of the baby. So avoid using the Apgar score to prognosticate for the parents. Go by the overall picture. In terms of recommendations, so the AAP statement clearly states that the Apgar score does not predict individual neonatal mortality or neurologic outcome, and it should not be used for that purpose. It's inappropriate to use Apgar score alone to establish the diagnosis of asphyxia. When a newborn infant has an Apgar score of 5 or less at 5 minutes, obtaining a cord blood gas as well as submitting the placenta for pathological examination may be valuable. So you have to look for other markers of intrapartum asphyxia to corroborate. So if your 5-minute Apgar is 5 or less, you consider sending the cord gas, both the umbilical, arterial and venous, and the placental examination could be considered in case there is chorioamnionitis or something that could explain the baby's poor condition at birth as well. The perinatal healthcare professional should be consistent in assigning an Apgar score during resuscitation. So the AACOG recommends the use of an expanded Apgar score that accounts for concurrent resuscitative interventions. So it's very important that you review and consider changing your practice if you have not started using the expanded Apgar score. So I hope this is helpful to you, and this is a very important topic for both obstetricians and pediatricians, neonatologists, midwives. I hope you'll be sharing this information with your colleagues. Thank you.